Welcome to Neuro Part 8, discussing hydrocephalus. So hydrocephalus, when you break down the word, means water on the brain. And just to review the anatomy and physiology, you know that this CSF bathes the nervous system, circulates through the ventricles, the subarachnoid spaces, and then it gets reabsorbed by the subarachnoid villi. So it's a feedback loop, so to speak. What happens with hydrocephalus is we either have a problem with the reabsorption or we have communication problems that results in abnormal accumulation of the fluid within the ventricles. So it's either not reabsorbed, overly produced, or it's going to be obstructed. So here are some pictures. On the left side is normal, and you can see all of the ventricles and the aqueduct of Sylvius. And so it goes around this, down the cord, back up again, bathes all the way around the brain. When you look at the picture on the right side, you can see that there's an impairment in the flow of the fluid. As a result, the ventricles become enlarged. And you can see that this is a baby. And at the it's not the very top, but in the forward section where the fontanelle is, it is bulging. It's not a nice smooth line like the picture on the left side. And here's another example of what it looks like, only it's a little bit clearer of a picture. And here's a little baby that has a very large head. And you can see how the pressure when the ventricles become so enlarged, it literally compresses on the rest of the brain tissue, and it exhibits the signs of increased intracranial pressure. Non-communicating hydrocephalus is an obstructive problem, so there's some kind of a blockage in the flow within the system. As a result, the fluid accumulates, and it never can get to the subarachnoid space in order for it to be reabsorbed. So there are a few things that can cause it. There can be a congenital malformation that causes a block. There could be a tumor. There can be a problem with a blockage of the aqueduct of Sylvius, which is that middle section of that ventricle system. There can be Dandy-Walker syndrome, which is another congenital problem that has not only brain problems but also heart and metabolic. There can be a Chiari malformation that is also congenital, and with this, it causes the brain stem to almost herniate right into the spinal canal. And then there's some other rare types. So this is a nice MRI of the enlarged ventricles, and wherever you see that real dark space, that's just looking at the brain, not part of the face. Don't look at that, but just look at the ventricles and all the fluid that's around the brain. And this picture shows this Arnold-Chiari malformation, and you can see where the brain stem should be on the left, but instead of it being on the left, it's pushed down towards the canal. When we have communicating hydrocephalus, there's no blockade of the flow itself. What the problem is reabsorption is impaired. And so we end up having excessive cerebral spinal fluid and an accumulation of that excess. What can cause the blockade of the surfaces of the subarachnoid villi? Bleeding. It can just block it so that it can't flow through and diffuse correctly. When there's an infection and there is pus, it leaves an exudate as well as fibrin, and that is enough to clog off the villi in the subarachnoid space. There are times that we can diagnose hydrocephalus just by a simple ultrasound when a mother is pregnant, and we'll see a very enlarged head. When we haven't diagnosed it prenatally and the baby comes out and they have this fairly large head, may or may not have that sunset eyes, but you will see some of those distended scalp vessels. Then they're going to do a cranial ultrasound and we'll be able to see those ventricles. And then in older children, because remember, you can also get hydrocephalus from a tumor, so the child was perfectly normal, the tumor develops, put pressures on the ventricle, and now this child has a new onset of hydrocephalus. And so we would see that on a CT or an MRI. And you can see the enlarged ventricles very well on these CT scans. The ventricles look like a large butterfly. And look at how large that is. And here you can see the Chiari malformation where everything is herniated downward. And this is an example of the Dandy-Walker malformation, and you can see a lot of fluid that is accumulated posteriorly as well as in the ventricles. And this is an example of not only enlarged ventricles, but there happens to be a cyst that has formed. What do we do about hydrocephalus? Do we just leave it alone? No. We have developed two methods of being able to shunt the fluid out of the brain. For the long run, we do what we call the ventricular peritoneal shunt. So it starts in the ventricle in the brain, and I put this picture in here so you can see how they're accessing into the brain, and then they put in the tubing within the ventricle, and then they're going to follow this white instrument, push the rest of the tubing all the way down into the peritoneum, and then take the instrument out. And so when you know your child has a shunt, when you're doing your assessment, you should feel for that shunt, and you'll feel it as it's exiting out of the top of the head or the top side of the head. Feel it as it goes down the posterior neck, and that's about as far as you can feel it. It'll usually stop right at the clavicle, but that's not the end of it. You just can't palpate it the rest of the way. The catheters have a one-way pressure valve, and so there is sometimes a palpable button that you can press on, and this helps any debris in the flow, the fibrin products. It helps propel it forward so it's going to go into the peritoneum, and you don't end up with an obstructed shunt. Some of them are programmable with a magnet, and it prevents overshunting, where this kid were pulling off way too much fluid in the brain, and so it's almost like the brain gets dehydrated. It's not really, the tissue isn't dehydrated, but there's no cushion around the brain. So these are some of the newer things that they're doing. And here's a nice picture, came from your textbook, where they put the shunt right into the ventricle, and then they thread it on the outside, behind the ear, down the neck. And here's another one where you can see it coiled into the peritoneum. And you see that it's longer than it needs to be, and that allows for the child to grow. There's quite a bit of extra shunt for this child so that we can have it in for many, many years. And here's a little one who has a shunt in place. They're usually not quite this prominent, but he had a pretty big head, and you can see how the forehead is really enlarged. Eventually, this should go down. So preoperatively, what we want to do is do a neuro assessment and see how affected they are. Do they have signs of increased intracranial pressure? We'll get their head circumference because we will compare that as the child is being cared for postoperatively. Prevent increased intracranial pressure by positioning the child. Respond to the child when they're crying. Prevent seizures as much as possible, and we do this by decreasing the intracranial pressure. You want to provide the patient, if they are developmentally appropriate, and especially the family, about what the shunt is going to do, the expectations after surgery, and the long term. So try and stick around when the neurosurgeon is in the room doing their pre-op teaching, and when they come back and say postoperatively what they found and what they did, so that you can reiterate to them, because they're on stun when all this stuff is being talked to them. If a child isn't a candidate for going to the operating room right away, let's say they have meningitis or they have some other kind of an infection, temporarily an external shunt may be put in. We give them antibiotics for many days, and then they'll go into the OR for a shunt replacement. Here's another example of a severe hydrocephalic child with the sunset eyes, and if you look closely at her forehead, you can see those dilated scalp veins. Postoperatively, we're going to continue to do the neurologic assessments, looking for signs of increased intracranial pressure, decrease in their level of consciousness, and for seizures. They shouldn't have any of these. If anything, they should be coming out of a depressed neurologic state. Don't lay them on the side of the body where the shunt is. If it's occipital, you don't want to lay them on their back. If it's on the right side, lay them on their left side or on the flat of their back. Continue to keep the head of the bed elevated. We tend to give antibiotics prophylactically because this is such a sensitive area, and we do not want it to be infected. Pain medications will be needed. After all, they were just operated on their brain. And the number one complication is an infection, and the number two complication is obstruction. And there's going to be a point in any person's life that has a shunt that either one of these things is going to happen. It can take years or it can take months. One of the newer procedures is a third ventriculotomy, and it eliminates the need for them to actually put in a VP shunt, and they're hoping that this, in the long run, will decrease the number of hospitalizations for these kids. So they put a scope into the third ventricle. There's a small puncture hole to create a natural flow, and this flow goes right to the subarachnoid space. And candidates for this would be somebody with a large ventricle and non-communicating type hydrocephalus. So this ends the lecture on hydrocephalus.